Welcome to the University of Michigan Dentistry Podcast Series, promoting oral health care worldwide.
Detection of the frank carious lesion presents no problem in diagnosis. When cavitation is present, the diagnosis is essentially positive, particularly if one has the opportunity of probing the dentin to determine its texture. There may be a time when there is cavitation and a distinction must be made between erosion and abrasion with the absence of the soft dentin. This example is a frank carious lesion. We observe here not only the cavitation, the absence of tooth tissue, but also the decalcification or demineralization of enamel and the undermining of the enamel, or the spread of the carious lesion along the dentin-enamel junction. If we take a look at the cutaway of a carious lesion, we see that there is the undermining of the enamel, the spread of the lesion along the dentin-enamel junction, the outline of the carious tooth tissue on both of its lateral borders, the pulp chamber that is being encroached upon now by the lesion, and it is this area of caries that will be removed. The original example of the carious tooth will be used to show the instrumentation of removal of carious dentin. The approach to the removal of carious dentin will be first to move laterally to remove the unsupported enamel, to establish an intact dentin-enamel junction, that is a firm and a stain-free dentin-enamel junction. From this point, we will move along the lateral wall, following then sound tissue, and clear the carious tissue away from the lateral walls at the perimeter of the lesion. Then lastly will be the removal of caries or carious dentin from that portion that is nearest the pulp tissue. From the radiograph of the extracted tooth, the one that we are going to be working upon is that shown on the right. We can see an outline first of the enamel, the dentin-enamel junction, following this on over, and then we pick up the outline of the carious lesion. Carious lesion, again, is the cavitation. It's the absence of tooth tissue, and therefore shows up as a radiolucent area. Certainly much more radiolucent as compared to the more radiopaque enamel. The outline of the pulp chamber blends into the carious lesion. Although the radiograph does not show an exact duplication of the anatomical relationships of the carious lesion and the internal form of the pulp chamber, it does tell us that there is rather close proximity, and indeed there may be an entrance of the area of caries into this pulp chamber. The instrument tray setup for the removal of the carious lesion will include the air turbine handpiece, the low-speed handpiece with its latch contraangle, the use of an enamel hatchet, the series of 3 spoon excavators, a cotton plier, a number 3 cow horn explorer, perhaps a friction grip contraangle, a dappen dish with tap water, the air syringe or chip syringe, the burr changer for both the air turbine as well as the friction grip low-speed contra-angle, and a series of burrs, a 56 plain Fisher burr, a number 2 and a number 1/2 carbide burr in the friction grip, and then lastly a series of steel burrs for the latch type contra-angle, a number 8, number 6, number 4, and a number 2. Finally, we will use some bulk cotton together with the tap water in the cotton pliers to periodically cleanse debris from the cavity preparation. Enamel that has been undermined by caries is rather weak. It can be fractured readily using an enamel hatchet with some firm pressure applied to the unsupported portion, and at times this is an expeditious way to gain entrance to the carious lesion. We'll move over to the air turbine with a number 56 straight Fisher burr in order to begin removal of the unsupported enamel and establish the intact dentin-enamel junction. In the laboratory situation, we're operating without the air-water spray coolant that is mandatory to be used, of course, in a clinical situation because of the adverse pulpal response that otherwise would be attained. We're clearing away the enamel that is undermined till we reach a point where the intact junction is present. We can take our cow horn explorer and observe the junction, both from the standpoint of the texture, and this we're receiving a rather clear chattering sound which denotes a firm texture to this tooth tissue. There is an absence of softness, and along some of the border of the junction there is stain-free dentin-enamel junction. Now what we would do would be to continue on around the peripheral portion of the lesion with the air turbine, and we'll remove the unsupported enamel back again to the intact junction, that is a firm textured and a stained-free junction. We see at this point we've cleared away a good deal of the discoloration, which indeed is not indicative of caries, either the presence or the absence of caries. The best diagnostic sign is, again, the texture of the tissue as probed with an explorer or with a burr rotating at lower speeds. We see here a more clear or less discoloration of the dentin, and then this fading into a rather soft textured, stained junction, and again the undermining of the enamel. We'll continue on and clear this area of the undermined portion of enamel. Whenever we reach a point where it is difficult to see the area because of debris, we would take a pledget of cotton and water and cleanse the area again so that we can have good visual access, and with the chip syringe carefully dry the area. Again, we can check the texture of the dentin with the Explorer, and we find that indeed this is still rather softened, that there is not the intact junction, particularly in this area underneath the mesial buccal cusp. Again, we'll continue to remove the unsupported enamel in the buccal and across the cervical area until we have the intact junction in the entire periphery of the carious lesion. We have now gained an intact dentin-enamel junction throughout the periphery of the carious lesion. If we look at this junction, it again is stain-free, it is firm in its texture, and we have established now an enamel area that is well supported. We have then at the dentin-enamel junction area established sound tooth tissue. We can begin now to follow that sound tooth tissue down into the lateral walls of the preparation, and then finally that portion of the carious dentin that is nearest the pulp will be removed. The spoon excavator, will be using the largest instruments that are available and will conveniently fit into the cavity as it is now prepared. Spoon excavators will be used to begin removing the caries from the lateral wall areas. Again, as we carry out this removal of the carious tissue, we find that we will be reaching then sound dentin beneath this area of caries, and we can follow that sound dentin down into the depths or into the deepest portion of the carious lesion. In this way, we can be most conservative then of the sound tissue and allow that greatest amount of sound tissue to remain as is possible. Again, the use of the Explorer, or rather the use of the spoon excavator, is one with a lateral scraping motion in order to remove this soft textured carious material. With the spoon excavators, much of the carious dentin has been removed from the lateral walls. Now with the area cleansed and with the Explorer, we can carefully check the texture of the dentin that remains and find that there indeed is some softness in this general periphery that I'm probing now. As we near the pulp area, the opportunity for pressure against the lateral walls with the spoon excavators becomes greater and greater. Therefore, the use of a slow speed contraangle with the largest burr possible for the particular area or carious lesion that we are dealing with will be used in a similar manner that we use the largest spoon excavator. Rotating at low speed, again the lateral walls are approached with a very light force of the round burr upon this tissue. It is a brushing motion, again reaching what we believe is sound tissue on the lateral walls and following that sound tissue down again to the greatest depths of the lesion. We'll stop again momentarily and with a dampened cotton pledget, cleanse the area of debris, dry the area with a chip syringe again so that we have visual access for checking the area for completion of caries removal. Still see softness of texture in the area near the cervical. The idea of having the area cleansed of debris is proper, because if a pulp exposure is to be made on the complete removal of the carious dentin, then that pulp exposure should be made in a clean field and therefore would be treated appropriately. Again, there is softness there, and we'll continue on with the removal of the carious material using the low-speed handpiece. And again, the texture of the dentin, particularly in this cervical portion, shows softness. And again, the touching of the explorer here is done with extreme care so that we do not inadvertently perforate that pulpal wall. So we'll continue then to cleanse that axial wall portion. We're operating here under the premise of complete caries removal with minimal loss of sound tooth tissue. We're firm in the upper portion of the lateral wall, and as we begin moving into the central portion of the carious lesion, this area is still slightly soft and will need to be continued, and I'm beginning to see here at my close view an outline of the pulp chamber. This tells me that we will probably, this will result in a carious pulp exposure, and this we might have predicted, of course, and did indeed comment on from the radiographs that we showed earlier. Let's finish the removal of caries carefully in that area. And determine the size of that pulp exposure. Of course, in a vital tooth, we would perhaps see hemorrhaging from this area. We're carefully laying back a portion of caries that has been pushed into the pulp exposure. We see here a pulp exposure that is of moderate to large size. It is certainly more than a millimeter in diameter, and indeed would not be a case that could be treated by a direct pulp capping procedure. The objective has been complete caries removal with minimal loss of sound tooth tissue. To accomplish this, we first established an intact dentin-enamel junction. Secondly, we cleared the lateral walls of carious dentin. And third, we completed the caries removal at its deepest pulpal penetration.
You've been listening to a presentation from the University of Michigan School of Dentistry, which is dedicated to supporting open learning and open educational resources. This recording is licensed under the Creative Commons. It may be reused and redistributed for nonprofit use. Please attribute materials to the University of Michigan School of Dentistry and redistribute under this same license. For more information on how this and other University of Michigan School of Dentistry recordings may be used, visit www.dent.umich.edu/license.